mean, what will happen? The motor part of the symptom will compromise. You have the shaking. Frequently, we call the tremor part or the rhythmic of the movement, which is different from the dyskinesia. And the slowness, and medical terms called bradykinesia. You may wonder why we're using so different all the terms. It's for billing. Just kidding. And rigidity or stiffness. And as symptom progressing, then it will affect in the gait and balance, the so-called posture instability there. Yes, and there are other phenomena like a speech swallowing affected. And also the walking, particularly patients have trouble freezing, like initiation or turning part, feel like the description is the feet glued to the ground. You couldn't move. Your body moving, your leg is not moving. That's called freezing. Okay. And yes, historically, when you have approach and managing of the Parkinson patient, I heard about when I walk in here, you mentioned about exercise. Yes, other than medication treatment, this is where so-called holistic management of a Parkinson. Yes, regular diet, good sleeping pattern, and good mental hygiene, which we always notice that depression, anxiety is very common in Parkinson, and sleep. Insomnia is very common, but not only just not able to sleep, but difficult maintaining sleep. And there are times maybe other medical conditions, maybe medication affect sleep, and plus REM sleep disorder, or so-called rapid eye movement sleep, is very common in neurodegenerative conditions like Parkinson's disease. So many patients have a multiple area of sleep disorder. So sleep hygiene, a good sleep pattern also improve good management or improve the overall function level too. Think about one night, just like us, sometimes we're on call. One night not sleeping well, next morning we're grumpy and we're not functioning well. And my office staff always notice he must be on call last night. In Parkinson patient, you're not just one night not sleeping well. Every night you have a broken sleeping pattern. How you're remain, yes, regardless of what level your Parkinson disease you are. I mean, and even the more advanced Parkinson patient, you still have some remaining dopamine cells left. And those dopamine cells working hard, try to produce dopamine, compensate what they lost dopamine. And plus the medication you're giving, they establish a normal balance there, try to help. But if you don't sleep well, those remaining dopamine neurons will not function well. And even you give it adequate medication, those medications are not working well. So frequently, and people notice that if you don't have a good sleep, and you might not function well next day. And of course, and we're talking about, hey, exercise is very important, balanced diet important, right? Yes, and management of the Parkinson symptom-wise and motor symptom management is important. However, it has to be individualized based on everybody's symptoms and overall of the tolerance medication. But yes.
I do have a question looking at a healthy diet. Protein to me is a very healthy food group, and it helps you to have healing and energy. But when you have Parkinson's, they tell you to stay away from protein. That's very difficult.
Protein diet, and her question is how the certain food and affecting your Parkinson medication, basically. And of course, everybody's diet is different. And for her, the protein is essential, what she thinks. Yes, I think we still, regardless of what medication you're taking, you still need to take a balanced diet. And some individual might need more protein than others. Now, it's not all the Parkinson medication are affected by protein diet. Only one class medication, that's the levodopa, okay? And doesn't matter immediate release, control release, or there has a combination with carbidopa, levodopa, and tacopone. This class medication, basically the active ingredient is levodopa. That medication is absorbed by the amino acid transporter in your gut. What is amino acid transporter? Which is the transporter, which is the port for absorption of the protein, basically. So if you're taking too much protein at the same time taking the carbidopa, levodopa, they were competing for absorption, particularly if you're taking close at the same time. So if you have too much protein, your levodopa will not get adequate absorbed, meaning they waste it from the GI tract, and your medication will not effective working, okay? So how are we gonna balance that issue there? And normally, if a patient is taking the reasonable protein, we're talking proteins not like just a little cereal, a little bit fruit, or even you have just a cookie or something. We're talking about the heavy protein. And like you're taking number of eggs and cheese and bacon in the morning, or you have big hamburger or barbecue, okay? So we're talking about the more heavy protein that will affect absorption. Now, when we talk about the food and diet, if that's the case, normally we recommend you taking your medication at least an hour, like the carbidopa, levodopa, hour before your heavy protein meal, or at least hour or two after the meal. But it's easy to say, sometimes the patient taking more frequent of the interval might not be easy. In that case, I would suggest don't take your protein a heavy meal in one single meal. You might divide it in smaller meals. That will be better. Now, it's so easy to say, hey, that everybody just taking 1 hour before the meal, that would be nice. However, this is where we're coming to the individualized of medication-wise. There are times people are very sensitive with medication, and if you don't take a little bit of food, and the medication will cause nausea, vomiting. So those individuals, even ideal situation, we like to take in the carbidopa, levodopa, empty stomach. For those individuals, maybe it's safer to take some food, even some cracker will be helping you. And rather than, hey, you feel sick all the time, what's good is going to be for your symptom-wise, right? Yeah. Yes.
Would there be a difference between a heavy animal protein as opposed to a plant-based protein competing for the amino acids?
No, in terms of what kind of protein affect your absorption, carbidopa, levodopa, wise, it doesn't matter what kind of protein. However, this has nothing to do with the plant protein or animal protein. However, in terms of the amount of protein, definitely when you're eating the steak, it will be much heavier volume-wise. Quantity-wise will be much more in animal protein than you are eating a salad, something, right? You need how much salad to equal one steak, that protein amount. That's a different there, yes.
One thing that we've seen a major improvement is we do not buy Greek yogurt because it's very high in protein. We just buy yogurt. So therefore it's like 5 grams compared to
So again, that's coming to the quantity of the protein rather than, yes, what type of protein there, yes. So you're still able to take an amount of the protein you need it if you divide in a smaller meal, smaller portion each time, probably. That one has less impact to the absorption of the levodopa, yes. Okay, so what is the, we talk about the food and any of the diet, and of course, and exercise. When I walk in here and I heard about exercise, a very important part of the Parkinson management. And not only exercise help your motor function wise, there are a number of areas exercise can help. For example, and definitely improve the depression, anxiety. If you regular exercise, maybe the group exercise have more interaction, even better. Exercise helps sleep. Exercise help the constipation. Those are not only talking about this improve the slowness, stiffness wise, but in long run, we're talking about regular exercise actually can slow down the progression of the Parkinson disease. This is actually a number of studies since the last 5 years, probably looking into that. And there are no specific one exercise might be more superior than another because it's not had a comparison. But in general speaking, if you can do it on a regular basis consistently, it will be more beneficial in the long run. And balanced diet, we're talking about, right? And yes, keep yourself well hydrated is also important. And of course, frequently Parkinson's associated with orthostatic hypotension. Not only just Parkinson patients have dopamine deficiency, and Parkinson patients also they have a degeneration called so-called a norepinephrine. So the other neurochemical also affect in Parkinson as symptom progressing. What is norepinephrine? Is another chemical in the brain which is regularly regulate your heart rate, your blood pressure, your blood vessel tone. That's the norepinephrine. As the norepinephrine level low, and Parkinson patients tend to have also low blood pressure, so-called hypotension, particularly when your position change, you're getting up, suddenly blood pressure drop could cause potentially orthostatic hypotension, dizzy, even to the point of passing out. So hydration is very important, of course, and fiber and contents can be also helping for the constipation too. And as symptom progressing, of course, the swallowing frequently affected, and that's where certain diets maybe need to change as well, from solid and sometimes soft, mechanic, and even pure diet. There are patients because swallowing process is significantly impaired, and if you have a risk aspiration, then other means of the feeding or the nutrition intake might be considered, for example, PAGDB. But that's not normally Parkinson patient early on. You would need to have the issue there. So this is where exactly talking about the heavy, high protein meal we mentioned about. It's not just a little of the protein we're talking about the amount of protein normally, okay? And so this is where we mentioned about taking the medication separate, not same time. Also, you may taking the protein and divided portion rather than taking one big meals, okay? Night sleep. And actually, we're talking about yes, and since we're talking about sleep, and we briefly mentioned about that lots of area in Parkinson patient can have a sleeping disorder. And we're not even talking about the other medical issue related, for example, sleep apnea, which is very common too. And just talking about the Parkinson disease itself with sleep disorder. Number one, REM sleep. Nearly 40% of the patient who has a REM sleep disorder might eventually develop into Parkinson's disease. Some of studies showing that REM sleep disorder can occur even 14 years before the Parkinson patient started motor symptoms, like the tremor or the slowness. And so REM sleep disorder and frequent can be an issue there. And most of the time patients don't remember is the spouse actually notice, hey, why you're hitting me? So, and frequently they feel like, hey, the patients feel like, hey, there's danger there, and is try to fighting back during the sleep. And Parkinson patient, of course, the Parkinson symptoms sometimes are shaken mostly because of the stiffness and discomfort, even pain, and affecting their sleep, and they're not able to maintain sleeping well. So the Parkinson symptom itself can affect the sleep. And frequently patients have either difficult falling asleep or difficult maintaining sleep, so-called fragment sleep. And yes, Parkinson affecting the bladder and the so-called overreactive bladder, and patients frequently waking up because of the bladder issue, and they can affect the sleep. And yes, we're talking about the Parkinson may affect the dopamine, may affect the norepinephrine that causing the blood pressure issue. And Parkinson disease also affecting the chemical called acetylcholine, which is a chemical regulate the sleeping in the brain too, which frequently we see Parkinson patients have actually the sleeping disorder. And sometimes Parkinson medication, if you read it, not happen to everybody. Certain medication can cause either drowsy and or insomnia as well. So it's kind of a tricky there. This is where when you have sleeping issue, you have to talk to the doctor in detail what exactly sleeping pattern. Sometimes even need a sleep study to identify what exactly the issue with sleep, to identify the cause of the sleeping issue and to adequately treat it rather than just assume what might be. Okay. And as I mentioned, that sleeping disorder is very common, and better management, definitely you see tremendous improvement overall, the function level wise. Okay. And this is where I don't think it's new to everybody. And we all know that mostly so-called hallmark of a Parkinson's disease is the dopamine deficiency. So try to better manage of your Parkinson's symptom. Of course, the major therapy or the main medication treatment is dopamine. Okay, and we're talking about all the sleep and the exercise and the management of the food and certain things, and that's complement what we're treating. But the major therapy is still dopamine. And there are three major class medication to try to help dopamine. One is, of course, the levodopa. Doesn't matter what formulary of the medication, you can have immediate release. That's called Cinemat or carbidopa levodopa. They have a control release. They have a combination with entacapone called Stalevo. And they have the so-called the medication with the gel, with the capsules called Ritari. So all different formulary, and even have a gel form as the intestinal duopa, but the major active ingredient still levodopa. This is the first class. Levodopa eventually converted into dopamine and make it easy to understand. It's called replacement of dopamine. Because you lost the dopamine, and this medication will convert it into dopamine. This is one class. Second class of medication, again, still working through the dopamine. That's called dopamine agonist. What is the agonist? Acting like a dopamine. So this class of medication don't need to convert it. It will direct stimulate dopamine receptor. And that's called dopamine agonist. That including, and probably many of you have been using Ropinirole or Requid, Maripax or Pramipexole, and a patch, Nupro. And there's a new medication, actually APOKYN or apomorphine. And this is a medication not for maintenance therapy, but for rescue. And when patients have a wearing off episode, you can have an injection subcutaneously. They kick in quick and relieve the wearing off episode. Third class medication, our medication can reduce the metabolism of the dopamine, which is called MMO inhibitors. And probably you are familiar with the medication Azelac or Resegeline and Xadago, as well as the old generation Selegiline. Some of you probably use it. Yeah. And there are other medications are not working direct through the dopamine, such as amantadine or glucovery, and that's a different mechanism. But mostly common use are dopamine medications here, okay? And when we talk about what a levodopa do and or dopamine medication do, most commonly you will say, hey, oral levodopa, right? And frequently, early and particular patients started with the medication, you will see working very well for mostly motor symptom wise. For example, the tremor, the slowness, stiffness, and even walking balance wise. It is a good medication. It's still, if it started since the late 1960s, well, it first started going to the markets in 1967. So it's more than 40 years, and levodopa is still considered the hallmark of the medical management in Parkinson's disease. It's still a very effective medication. And it worked really well for most of the motor symptoms, but some of no motor symptoms even improving. For example, patients feel like the clouded mind improving, the anxiousness better too when the medication is working. But the Parkinson's symptom actually don't stay at the same level. they are going to progress over time, although slowly progressing. There are some of the certain signs and symptoms are not responding well to dopamine therapy as well. For example, cognition, dementia, and depression, anxiety. Even during the anxious area, when you're wearing off, the medication may work, but they don't work for the underlying dementia, the depression, anxiety. They don't work well for swallowing and speech. And if a patient has significant freezing, those freezings not during the off time, and the dopamine medication may not work, because that's where complement with some of rehab, speech, and physical therapy may work better too. Okay. And yes, inevitably, and the condition will slowly change. We seen, yes, it is a progressive condition because the dopamine neuron will continue to degenerate, although slow. Okay, we made tremendous improvement in management of Parkinson's disease over the last 30 plus years. And if many times when first time if a patient come to see the office, probably the first question that came out after the diagnosis of Parkinson, how long I'm gonna live? Of course, many patients worry about because they label as a progressive condition. Let me give you an example. Before we have all those treatment available in early 70s, average Parkinson patient lived, guess how long when they started condition? About 7 years, a little over 7 years, which is about similar as many of the PSP patients. Probably you heard about it, the so-called progressive supranuclear palsy. And it's one of Parkinson plus syndrome, and we don't have much treatment available. Why is that back then? It's because we don't have a good treatment available. Over the years with all the new therapy, with a much better understanding how we treat the condition too. And now, average Parkinson patient live about how long? 20. Close to 17 plus years. So as I already mentioned that Parkinson is, yes, commonly affecting the elderly population. Most common is to start 65 or older. So if you start a condition at 65-year-old plus 17, how long are you going to live? Average about 82-year-old. What is the life expectancy here?
79.
Exactly. So Parkinson, again, Parkinson do not short your life expectancy, period. Parkinson patient live, yes, you might, Parkinson patient live long enough and maybe in other conditions. That's something, I mean, I have many patients died of cancer, died of a heart attack before the Parkinson is really bad. So Parkinson patient actually don't die from Parkinson disease, okay? But normally, yes, inevitably, even with all the good treatment and symptom will progress, and nearly 50% of Parkinson patients will experience some wearing off, okay? And some of the actual wearing off can occur. This is where as early as 2 years, this is where sometimes it's coming to where you start your treatment, how your neurologist started. Yes, that does show the difference. The early wearing off, and I see frequently people too aggressive with certain medication, like a short half-life medication and pushing too aggressive, too high of a dose. You might push in, yes, when the first time you see it, you're very happy with the outcome, but in the long run, may not be a good approach. That's where you see the early of the wearing off within 2 years. But most frequently, yes, after 5 years, and inevitably, Parkinson's patient will see some wearing off. As symptom progressing, the wearing off symptoms tend to be more frequent and longer too, okay? Yes, levodopa at a time when you have the wearing off, then the result may not as predict as the early on, but I hate the term, quote unquote, honeymoon effect. That's the misconception about the medication. Honeymoon effect means, hey, only working for a few years. That's not true. The levodopa is still working, but it's just disease progressing So think about when you start the condition 5 years ago, you still have this much of the internal dopamine neuron left. But over time, you continue to lose some more. So your oral dose is not going to remain the same level. You're going to need an increased more dose to try to compensate the loss. That's why the medication effectiveness gradually declined. However, to a certain point, everybody tolerates medication different. To a certain point, the dose high enough, then you may not able to tolerate the dose. You have more of the side effect with the medication too, right? So the wearing off can happen in many different forms. There are times and patients started having the wearing off so-called early morning. The first dose either taking too long to kick in, that's called dose failure, or delayed on. There are times when patients very predictable before next dose, your symptoms start. That's the classic wearing off. There are times unpredictable and random on and off, and happens any time of the day. That probably is the most challenging type of the wearing off to be managed. Fortunately, that's the very, very small percentage of patients have those there. But if it happens more common and more advanced over the Parkinson patient population, why Parkinson patients have the frequent wearing off? This comes to a combination of the disease and also the medication as well. The disease-wise, number one is the brain continue to lose the cells. Number two, Parkinson, we've seen, obviously, you see in your motor symptoms and the shaking, the slowness, stiffness-wise. Parkinson affect the patient from head to toe. Mostly, we've seen affecting the medication-wise is the GI tract, okay? Gastroparesis is very common in Parkinson patients. Nearly probably 70% of Parkinson patients have some form of the gastroparesis. What happens when you have a gastroparesis and when you're taking the oral medication, the medication don't pass your stomach. They don't get to the small intestine for absorption. And plus, early on, we talk about food. So the food content will affect the absorption of the medication as well. That make it the medicine absorption-wise not as predictable that itself at the wearing off. Plus, and the medication itself, as we say, carbidopa, levodopa is a very common medication for Parkinson management. Many times when you see the medication benefit, you're going to know, hey, how is this medication half-life work, right? The longer half-life medication will be able to sustain the benefit longer, even to patient, some medication patient need only taken once a day, some of them even taken once a week. Why carbidopa, levodopa has to be taken every few hours, and most frequent, probably every 4 hours, but sometimes even shorter as disease progressing. Why? That comes to the nature of this medication. Levodopa half-life is only 60 minutes. Even add carbidopa, that make a half-life 90 minutes. That itself, most of the time we using the calculation, 5 half-life and medication will completely eliminate in your body. So if a 5 half-life, 90 minutes, it's only 450 minutes is complete out of your system, but reduce probably by half, you only take roughly about 4 hours, average. Some patients may last a little bit longer if you have enough endogenous dopamine. Some patients may last shorter if you don't have enough endogenous dopamine to help. So that's where sometimes and the half-life make it tougher for this medication to make it last longer, okay? So this is talking about gastroparesis and why the absorption is impaired. And this is actually very unique as one of the Parkinson patient taking one of the tablet. This is not carbidopa, levodopa. This is just a levodopa. 90 minutes after taking medication, the tablet still remain in the stomach. So because of gastroparesis and the medication not able to get to the intestine for absorption, of course, not working For this patient, after if it's 60 minutes, medication not working, definitely is considered dose failure. Okay. Again, how common it is, and nearly 90% of patients, if you randomly look at all the pocket information, nearly 90% of patients eventually are going to have some wearing off. And about 65% of off actually for more than 2 hours a day. If it accumulates the time, that definitely have a significant impact to patient quality of life. We're not talking about the even sleeping time. We're talking about just the awakened time, okay? And 50% of patients actually try to avoid the essential activity because of wearing off. Yeah, I mean, hey, if you're not functioning well, I'm afraid of falling, you're not going to go in and out, you're not doing the things that you like to do, right? Yeah. Why didn't they have that one? Interesting. It seems like we don't understand that part. So what the treatment actually, other than many of the medication treatment-wise, and yes, there are also some patients going for surgery-wise. There's a new treatment available for wearing off. And I guess we have actually patients using the medication. They probably can tell you what their experiences are. So this comes to APOKYN. It's called, and the main ingredient is apomorphine. Is a dopamine agonist. Earlier on, we talked about 3 different class medication. This is a medication directly stimulate the dopamine receptor. This is a medication can be used for rescue treatment of those wearing off, and this is FDA approved for the wearing off management and has been a market probably about 7-8 years now, actually. So, of course, this is what indication is approved for some actually wearing off in Parkinson disease. It's not replacement of an oral medication, okay? And do not take an apomorphine if you treat it with a certain so-called serotonin medication for GI. One of the classic medications they're talking more likely is the so-called Zofran, okay? Because patients taking dopamine medication frequently have the nausea, vomiting. There are times we use certain medication to help the nausea, vomiting, but try to avoid Zofran. And if you combine with Zofran, you could cause severe orthostatic hypotension, means the blood pressure bottoming up. There are different, if patients have really significant nausea, vomiting, there are different medications like a Tigan can help with nausea, vomiting. Try, of course, your prescribed physician probably know this. They should know this, not probably, they should know this. And certain medications not proper, okay? And this is the sentence frequently happens, has nothing to do with the medication itself, but this, any medication, the lawyer language. If patient is sensitive or allergic to the ingredient of the medication and patient's contraindicated, patient hasn't exposed to the medication already, so how do you know it's allergic to, right? But this is a lawyer language anyway. But bottom line is, if, of course, if they're allergic, they cannot use it. Okay, and this is simply just talking about to your physician and about using the APOKYN if it's doing that. If you have a side nausea, vomiting, the Tigan as a medication can use it for nausea, vomiting, and to help. Okay. So what is the difference? Yes, go ahead. What's that? Inbrija, okay.
What's the difference?
What is the difference of the APOKYN and Inbrija? Yes, it's a good question. Both medications are using for rescue therapy of the wearing off. APOKYN is apomorphine. Okay, that's number one different because this is a medication directly stimulate the dopamine receptor. Inbrija is levodopa. So that's the one to replace the dopamine. So the ingredient is different. That's number one. Number two, this one is given subcutaneously and Inbrija is inhaled. So the delivery system different. Number three is that they all tried, there is similarity, they all tried to bypass the GI. Why? We're talking about Parkinson patients have GI issue. So this one is injection and the other one's for inhaler. They try to bypass the GI. So they're able to get to the brain, the plasma and eat quicker and get to the brain quicker to improve the wearing off. That's why they're able to use it for the wearing off episode. Now, there's no head-to-head comparison, hey, which one is better or which one is safer. However, if you look at know the ingredient wise, yes, levodopa is a common use for carbidopa, levodopa. Of course, if you're able to tolerate carbidopa, levodopa, likely you tolerate the Inbrija well. However, because of this going through the pulmonary inhale, most common side effect is a cough. Okay. Now, have the APOKYN is dopamine agonist. So if a patient taking dopamine agonist orally, like a ropinirole or pramipexole or the patch and Nupro, chances are you might be able to tolerate this medication well too, because of the same class medication. However, dopamine agonists, you all know that common side effect like drowsiness and the blood pressure drop, and sometimes confusion, hallucination. So each one, they have their own potential side effect, a tolerance issue there. But based on what might be the class, if you have been taken, then you should be able to tolerate better too. Yes.
So first of all, I will say that the antagonist is this.
Agonist, yeah.
Agonist, that one. My husband is on the Neurotech.
Yeah.
Years. And it is the reason I believe why he does so well. It really inhibition. However, every time we go into the doctor's office, they say, have you felt impulsive? Have you had problems with gambling? And have you had sexual issues? What is that? And so is that the same thing with this report?
Well, as a physician, we have to be sure it's safe. So as early, very beginning, I mentioned about 3 dopamine systems. There are 2 dopamine, one is for the motor symptom, the Parkinson relate. Second is the accumbens, the psychiatrist frequently use that rewarding part of the brain. So ideal situation, when you're taking the dopamine medication, doesn't matter which class. It should activate all these 3 dopamine systems. They all could potentially have in that impulse control disorder. It doesn't matter if it's dopamine agonist or just levodopa. If you look in the fine prints, actually every Parkinson medication will have that label, safety-wise. It's a matter of the percentage, which one might be more. Okay, so if you look at all the dopamine, you're taking dopamine to your brain, I wish you have an ability, just, hey, you tell your medication, just going to that motor part of the brain, not to the other part. That would be nice, but we can't. We're not able to do that nowadays. We're still, the dopamine medication going to the brain is going to affect the entire brain. But the impulse control disorder is always going to be asked. It doesn't matter which medication you're taking, and depends with which doctor. If it's a doctor notice that what they prescribe, they're going to ask. Doesn't matter what class of medication. It's just the precaution wise. Okay, I think it's a good practice. They're going to ask that. If otherwise, I mean, you don't know what might be the side effect. However, overall, the side effects still relatively low. Okay. But doesn't mean it's not an issue. There are some, for some individual, it could be an issue there. However, this is looking back, and this is almost like 8 years ago, the first studies published is from Mayo Clinic. They published about 13 patients who's taking pramipexole has the impulse control disorder. Among those, actually, about 9 patients have a pre-existing potential gambling behavior to start with. Meaning, yes, it's not everybody taking the medication will have the potential side effect. There are some individuals who are more prone to have it, and people who have pre-existing gambling behavior, yes, or pre-existing hypersexual activities, they tend to be worse. And since we mentioned about the ICD part, it's funny about this presentation, men and women tend to be different. Women tend to go into like a or the impulse eating and going shopping. And men tend to have more gambling and hypersexual. So why APOKYN? Actually, APOKYN is subcutaneous injection. Number one, they're quick, rapid. Within 10 minutes after injection, you will see that it started working. And that it is why we're using this medication for rescue, right? It can kick in very quick. And reliable, 95% of the patients actually were not episode were successfully reversed after about 20 minutes. And the peak within about 30 minutes, okay? And 90% of the patients achieve their best level of motor response when they were taking the carbidopa levodopa, meaning when you're taking the carbidopa levodopa fully on how much of the motor symptom improvement, and the APOKYN, 90% of patients taking APOKYN, they can achieve that level of the motor symptom improvement. That's why they say it's a robust, reliable, and rapid improvement. Okay, and 97% of patients actually can help the morning wearing off. And many patients wearing off, one of them is the first dose is taking too long to kick in, or sometimes even dose failure, right? And 96% of patients saw improvement in the time and to on in the morning, actually APOKYN compared to the oral medication, meaning with the APOKYN intake, not only the morning on quicker and their first dose or carbidopa levodopa might working more efficient as well. So this has come to the same you mentioned about ICD or the impulse control disorder. Any Parkinson medication, you're gonna have the same laundry list of the potential side effects. Yes, this is dopamine agonist. So most common dopamine agonist side effect including nausea, vomiting, the GI, the drowsiness or yawning, which is very common, blood pressure, also static hypotension, to the point even passing out or syncope, and the impulse control disorder, okay? And most common those are side effects, probably is gonna mention that. And dyskinesia could happen, again, if you are using medication to enhance or increase dopamine activity, yes, potentially could have dyskinesia. So what is APOKYN used? Is used to, along with your other Parkinson medication, it's not replacement of oral medication. It's using for subcutaneous injection for the wearing off. It can use in up to 5 doses a day, but you cannot take in the second injection within 90 minutes. Why is that? Because the effectiveness can last up to 90 minutes, so you don't want to accumulate more of the potential side effect there, okay? And it's very small needle, although we talk about small needle, and it's funny, I never noticed so many people are needle phobic. So talking about the needle, as a man, I feel shame. Actually, ladies tolerate needle better than men. Over the years, I've seen that. And many times, I've seen a big muscular type of man. They say, I'm afraid of needles. I say, it's kind of strange. And which is a kind of reality there. And ladies, unfortunately, tolerate better than us. And APOKYN works quick and reliable in as little as 10 minutes, okay? And once actually trained, well, they have actually a good support system. They have a nurse, visiting nurse, go into your home and teach you how to using the device, how to do the subcutaneous injection and monitor you the safety-wise and train you. And after train, actually, you can easily use the needles, just like the insulin injection needle, it's very tiny, and can be used up to 5 times a day. That's what here, okay? So Dave, we have, so we're not gonna use Dave, but we're gonna use you, right? So we're gonna skip here, we're gonna use you there. So this is where the gambling, you see the impulse control disorder here, and they inevitably every medication, as a matter of fact, in the future, any Parkinson-related treatment, probably they're going to have the same label. It doesn't matter. During the trial, even it's not reported, they're going to have those similar label there too. So impulse control disorder. However, one thing though, because this medication, dopamine agonist, potentially they can drop the blood pressure. If patients have cardiac, you have the significant cardiovascular risk factor there, and recently have a heart attack or any angina there. So probably it's not safe to use this class of medication. Maybe at least get the cardiology evaluation before we started taking this class of medication there. Okay. So this is where probably Chris can tell you, and you don't need to worry most of the time. Actually, how we're going to start it, they have the so-called circle of care, and the physician and fill the prescription. This is to go into the specialty pharmacy, and the specialty pharmacy usually verify your basically insurance-wise and tell you how you're going to obtain the medication. Sometimes even you cannot afford it, and they can have actually the third-party grant can help patient obtain the medication. I have a number of patients with the system for the help. And the circle of care is not only just give you medication, but they have a nurse, visiting nurse, then teach you how to use the medication and for the treatment and monitor wise. Okay, and Chris probably going to give a little bit of detail on how they're going to use the circle of cares. Okay. So we talk about very much so empower. Basically, you're gonna using this medication, and actually this is a question. What is wearing off? Probably they try to. Hey, you're gonna monitor yourself. Hey, do you think you are a candidate for the APOKYN? So do you have wearing off? Do you think this medication may potentially help you? The better way is that sometimes, after 3-4 months, then you visit your doctor. When your doctor asks you, might not easily remember all the signs and symptoms. Better ways to document. Hey, when I start taking medication. Hey, when I started my first signs of symptoms, or what kind of an issue we may have after taking medication. When you're looking back, doesn't mean you have to record it all 3 months at least. You record it a couple of times a week and a couple of days a week, and you have a detail what looks like a better way for the physician to see what's your pattern, your medication intake, how long taking effect, and then the potential wearing off happens early morning or between the dose or random off. That might be much better, easy way to identify the cases there. Okay. So again, this is not replacement medication, is using for combination with oral medication, but using for wearing off episodes. Okay, can help you, of course, not only just walking, overall function much better as well. I think this is all of them. And before I give it to Chris, any other questions? Yes.
You showed a slide that indicated people having problems with their gastrointestinal system, and we have heard that some people recommend chewing the tablet before not just swallowing this whole.
Yes. Many of the oral medication is a tablet or capsule for swallowing, right? So her question is that if they chew in the medication will able to overcome the gastroparesis, make a medication kicking quicker. Yes, there are some benefit by chewing the medication and make it kicking quicker, and particularly with those, you see the big tablet stays in the stomach. So the chewing might able to overcome some, but it's not good enough. That's number one, okay? Number two is that after chewing it, but you need your medication last longer too. It's not only just kick in. Then after chewing it, first dose might not last long enough too. So frequently in those cases, if a patient's not willing to do any other, just using the morning dose, I might combine other than chewing. You might chew in half tablet, allow that dose kick in quicker, but swallow another one or another half. So kind of a different way. Sometimes using that, but doesn't mean it's the best. And you can't overcome that gastroparesis part. You can actually improve some of the absorption issue there. Yes.
Is there any definitive test to tell how much the dopamine in your body?
There are definitive tests of how much dopamine in your brain. And that's what you're trying to say. And before we start the treatment?
Yes.
Okay. Well, one of the tests is called DAT scan, the DAT scan, which is a measure how much dopamine and if inside the brain. That's where actually we frequently using that to confirm the diagnosis of Parkinson's disease clinically. Most of the time we don't need it, but there are times some of the challenge cases are not clear. You might need that. Yes, Parkinson's patient show dopamine deficiency, and if you don't have Parkinson's, your dopamine level is normal, right? However, this test is kind of a semi-quantitative test. So you can use in that, make a diagnosis of Parkinson, but you cannot use in that for management, meaning, hey, this patient has how much of the dopamine needed. That's not sensitive enough to tell you that.
Do you think that eventually will come to that?
I hope, but again, even you measure dopamine in your brain, that's still how we're gonna get that level is not easy too. So in many times, for example, patient have absorption issue, and many times the patient's medication might be different too. For example, you use dopamine, like a levodopa, you might be able to measure dopamine concentration, but if you're using dopamine agonists, they're not be the same as the dopamine in your brain. So that measurement is not the same. So it might not be that easy, simple, say we're able to achieve that yet.
That they have that make it easier for treatment.
I wish that ideal situation is like that, but that might not be easy to achieve. Yes. If we can use in the APOKYN, this is the subcutaneous injection with the Inbrija, the inhaler, to help the wearing off. Because they are working different mechanisms, ideally you might, however, you have a hard time to convince your insurance to pay for both. If you're lucky, yeah.
Okay, I have a question about just toxicity. We're fortunate to have two doctors because we live north, so we have a University of Pennsylvania movement disorder doctor.
Who's that?
Dr.
Cremus?
Dr. Kremis, we used to have.
Yeah, Daniel Cremus. Yeah, and a good friend of mine. I know him. Yeah.
Anyway, Dr.
He used to be the UPenn. Yeah, he moved to Jefferson. Yes.
Right. So anyway, so we're fortunate. We have her. We see her once a year. She errs on the side, flushing the dosages of carbidopa, levodopa. And then when we're down here, we have a new doctor. We love him. And he said, I don't think you have to worry. We're sending your medicine out. So why worry about toxicity? What is your thought?
I'm not sure we can easily use the term toxicity. And why is that? I mean, yes, everybody tolerates medication differently, but most of the time, probably when Parkinson, we talk about Parkinson, not toxicity issues, the side effect we talk about. Okay. And they are, because everybody tolerated even same medication. We see even little tiny lady, they tolerate twice as much as the big man. So the body, the metabolism is different. And it's based on what you measure the patient's adequate. One is the adequate improve your symptom, but minimum of potential side effect. That's where it is. And when you talk about toxicity, if you're able to measure the amount, how much is the over the threshold, we're not measure those. Yeah.
For so many years.
Yeah.
We're like 14 years in.
Sure.
So for over, the medications are increasing year by year, and then it's like, okay, that's enough increasing. So now we do the amnesia for the off times, which is working out really well. And this is really also, that's a huge breakthrough. I didn't know.
Sure.
I never heard of it.
Sure.
So we have options here with Parkinson, which is a blessing. Yeah. It's a lot different than other neurodegenerative diseases. Where we have a lot.
Exactly. I mean, yes. I mean, I wish we have a cure, but as I already mentioned, that hey, from patient lived about 7 years, now we extended 17 plus years. It's a tremendous improvement there. Yep. Okay. Thank you.
Dr. Huang. Now we've got a couple of people that came here all the way from Philadelphia. They're actually users. Joe, who is the husband to Sarah, lovely people, both, has Parkinson's, and they both been experienced with the medication APOKYN, but some other things too. They're going to talk to you a little bit about their trials and tribulations and how they deal with Parkinson's. So I'll turn that over. This is Joe and Sarah.
Thank you. Thank you.
Thank you. It's a real privilege to be here and a pleasure. I want to thank Vince for having us here. It's great. Being in Daytona is a lot nicer than being in Philly this time of year. So I used to own a property in Norman Beach, so I love this area. When my dad died years ago. But it's really nice to be here. We flew in last night. We've been doing this for 5 or 6 years. I'm 56. I was diagnosed when I was 42, 14 years ago with Parkinson's. So I've seen a lot of changes in the last 14 years. Dr. Tremors is my doctor. I've seen Jefferson. Yeah, you're talking about that. Great doctor. But what we like to do is tell you a little bit about how I came to be getting the Parkinson's, and then how APOKYN has really helped us change our life, our quality of life, and going forward. But I was born in Philadelphia area. I grew up in a great family, healthy. I had 4 younger brothers, all big guys, very tall. They all played football. I played college football at Temple, and then I played a little bit. I was a free agent with the Philadelphia Eagles in 1988. I got released, and that's when I went to work. I had an accounting degree. My dad was a CPA. I went to work with my dad, and things were going good. We're healthy. My dad was healthy. My mom was healthy. My brother had diabetes, so we had a really good life. I had great parents, and things were going great. And then my dad got sick. In my mid-30s, I just got married. He got sick with a muscle disease, and we watched him progressively get worse and worse. So he passed away in 2008, and I was having symptoms that they thought was the muscle disease. And so I was living with it, and a few years passed, and I was starting to get a lot of stiffness and pains in my neck and my back and stuff. But I didn't do anything. I thought it was just old football injuries. So I just dealt with it. And at the time I was married, and I had 4 kids. So I was working hard. And then a girl I hadn't seen in a long time came to my office and thought I had a stroke. And, I think see a girl, I hadn't seen a girl in a while. She said, you look pretty good for 40, but she said, but I thought I had a stroke. So that's when I decided to go get checked out. And I went to an orthopedic. They ruled out any kind of big injuries from the football, from the stiffness. They said, go see a neurologist. And it sort of caught me off guard. I was like, neurologist, I'm fine. And I walked in to Dr. Kremen's office, and within half hour or something, they said he had Parkinson's. And he knew by my movements. I didn't realize at the time I was moving really slow. I was kind of slurring my speech. And so my mom was with me at the time. And I was pretty shocked driving home. It was a quiet drive home. And my mom was, Joe, you're going to be fine. She was a nurse. You're going to be fine. And, we got pretty upset. And, thank God my mom was around. She really let me through this stuff. I get sort of thinking about it. But we went home. My brothers are like, all right, get ready. We're glad you have Parkinson's. Go out back and start shaking the martinis together. Like we're joking about it. But so I went and diagnosis. I was 42. And I went for like a year and a half, 2 years, and didn't do anything. I didn't do any research. I didn't exercise. And I liked to exercise. I was playing ball. I really let the disease kick my butt. And it was a shame because I look back on it now, and it wasn't right to my kids. I was afraid to do things. I was embarrassed to go to their games. I was slipping and fall. The disease was progressing. And it got to be real difficult. And my mom, thank God, said, Joe, you gotta, I was going through a divorce at the time, which didn't help. And my kids were 4 young kids, and having my dad pass, I had to take over the business. And things weren't real bright in my life. My mom's like, Joe, you gotta get off the bench here. The kids are counting on you. Maybe you go try to meet somebody. So I figured the 4 young kids, pushing 50, Parkinson's, I'd be hell to catch on an online dating site. So I went on the site, and if we had a couple of days, couple hours, I would let you know how some of the dates girls ran out of the bar, right? Because I'd over medicate and I'd be all over the place. Just knocking stuff off the table, knocking the checks. And if you saw the frightening look on some of these girls' faces, you'd laugh. And then with online dating, if you don't hit it off right away, and the date ends. It's like shake hands and on your way. Well, I finally met someone, and I have really bad vision, bad hearing, and she decided to give it a slap. So that's when things started to change for the better for me, and Sarah comes into my life.
That's right. Is this on?
Yes.
Okay. You guys can hear me okay? Or I'll hold it closer to my mouth. Okay. So Joe and I did meet online, and I will never forget our first phone call, because it was about 2:00 in the afternoon on a Sunday in April. And I could not understand a thing that Joe was saying. I had to keep asking him to repeat himself, slurring his. And at one point, I remember leaning over to my daughter, who was sitting on the couch next to me, and saying, I think this guy is already drunk. So this red flag went up for me. But Joe invited me to lunch the following week, and it was on my lunch hour, and he met me in downtown Philadelphia, and Joe was late for our first date.
Who with Parkinson's in here is on time for anything?
Yeah, these guys were all here on time today.
You can't parallel park, you can't do anything. You're going to be late.
No. So by the time Joe got there, I was like, that's it. I'm done with this guy already. I'm having the lobster and he's paying. So Joe got to the restaurant, and we sat down, and we had a nice lunch together. Joe really lifted my spirits. He made me laugh. He walked me after lunch 7 blocks back to my office, and he asked me if I would see him again. And I said yes. And after Joe left, I called my oldest daughter, who was in college at Temple, to let her know that I was okay. Because your first date is a blind date, right? And I told her about Joe, that he was actually tall, dark, and handsome, that he did not lie about his height online. And that and he did pay. And she was like, oh, that's great. And I said, yeah, I think I'm going to see him again. And she said, that's so great. And I said, yeah. I said, there's just something about him, though. She says, what? And I said, I think he either has Parkinson's disease or maybe MS. And she just said, oh my gosh, Mom, you have to find something wrong with every guy you date. She was like, maybe it was just, I didn't think Joe was just nervous. And the reason why is because my uncle has had Parkinson's disease for about 30 years. And some of the awkward movements I saw with Joe, especially in his hands, were very similar to what I'd seen with my uncle. My uncle had gotten it when I was in college, and it had progressed and progressed. He had horrible tremor. He got so disconnected, he was falling all the time. We were at my cousin's wedding in Boston, and he was trying to film well wishes for the bride because he's this big ex-IBM exec and he loved his gadgets. And he was just all over the place with this camera. And we thought, we're going to get a call that he's passed. Well, 3 years later, call never came. Now we're at my brother's wedding out in California. And my aunt and uncle are there. And he's walking around and he's dancing with my aunt. And I said to my dad, what the heck with Uncle Dick? He looks great. And Dad said, oh, yeah, he had that brain surgery and he's even driving his RV again. So I tell you all this story because on our third date, Joe told me that he did, in fact, have Parkinson's disease. And that was the story that I told Joe that I knew it wasn't a death sentence. And then Joe went on to tell me how different his Parkinson's disease is from my uncle's.
Yeah, I figured I better tell her I had Parkinson's because these lobster lenses are getting real expensive. So I figured she'd run out the door. She didn't run out the door. And that was pretty much, I use the analogy, it was like she got on the high dive of a pool and jumped in, there was no water. And she could have run out the door. She was perfectly healthy. And I didn't know what to expect. If you guys know that have Parkinson's, it changes, like it seems like every hour things are different. You're feeling great, and all of a sudden you start getting bogged down, you slow down, you freeze. I mean, I'd be typing away some days and all of a sudden, with no rhyme or reason, I'd be down to pushing like one finger. At a time, everything would get stiff. And then you get I tell people a lot with the Parkinson's, the motor symptoms are tough with stiffness. I don't have the tremor, I have stiffness and freezing, but the non-motor symptoms are brutal. The apathy, the depression, the lack of focus, the lack of multitasking, they weigh on you a lot more, and anxiety builds up. And the more anxiety builds up, it feels like the symptoms are enhanced. So we started dating a lot and seeing each other quite a bit. But I was much happier, feeling great, but the symptoms were getting worse. I didn't see them, but I knew they were getting worse. And I still had a tough time I was afraid to go into banks. I was afraid to go into stores by myself. You're trying to get money out of your pocket to pay for something, and you can't get your hand, you're freezing up, and the line's building behind you. You get anxiety. I couldn't get my money into the tube to put it up in the bank. Stuff you take for granted became real difficult. And so finally, Sarah said, I have a great doctor, Dr. Tremors, and you see him every 6 months. So twice a year. So Sarah asked if she had an appointment coming after about 6 or 7 months of us dating. And she asked if she could come along.
Yep. Yeah. And Joe said yes, that I could. And that day I kind of deemed myself Google doctor. And I went online and I researched everything I could find out about stiffness and rigidity in Parkinson's disease, because I wanted to come with questions. I talked to my aunt, to my friends who I knew who had family members with Parkinson's. I signed up for Michael J. Fox newsletters. I looked for support groups. I did everything that, I thought that I could show up with some intelligent questions. Another thing I did was I wrote some things down that Joe was doing that I thought that Joe was just kind of acting like it was his it was his normal. But I thought maybe they were symptoms that we could talk to the doctor about. So on the way to the doctor that day, Joe was driving, and I'm saying, Joe, you need to ask him about this. And he's like, okay.
I'm just trying to keep between the lines. And then we just said we can't multitask, so I figured driving's more important than listening.
Yeah. Well, one ear out there. We get into the doctor's office and sit down. Doctor comes in and introductions and all the niceties. And then the doctor says, so how are you doing, Joe?
And what I did for 7 years, twice a year, I tell the doc, I'm doing great, doc. And then when I said that, I could see the smoke come out of her ears. She was like, no, he's not doing good.
I just leaned right over Joe to the doctor and I said, no, he's not doing okay. I said, it takes him sometimes 2 hours to get going in the morning. It seems like the pills don't digest. Does he have to set an alarm for like 4 a.m. in order for him to take a pill to go back to sleep so he can get up at 6 or 7 and be able to function? And I said, and then for some reason or no reason, it seems like the pills just shut off, especially with stress. It's like flipping a switch. And I said, then the other thing is that his solution to wearing off early was to take an extra pill or an extra half a pill before it was time to take it. Well, I would come back to Joe's some nights to cook him dinner. And it seems like all the pills had digested at once. And he would be so dyskinetic, he wouldn't be able to get a fork up to his mouth or spin it in the spaghetti. And I just said, there's got to be something we can do differently with these medications. And so the doctor patiently listened. And he said, no, Joe doesn't need to get up at 4 a.m. and take a pill. He said, we have something that will help treat this. What you're describing are off episodes.
That's the first I'd heard what an off was. I mean, like Sarah said, I thought it was my new norm. I have to live like this. Things are going to progressively get worse. I have to deal with it and adjust to it. And, and that's when he told us that you don't have to deal with it. There's things out there that can help you with your offs.
And he said, He said, we have something for this. It's a subcutaneous injection.
And I enjoyed that moment because that was the first time in 8 months she was actually silent. I knew what it was because my son's a diabetic.
Yeah.
He takes the needle. So she had no clue. And
I did not.
enjoyed every minute of that.
No.
What did I get myself into?
I did. Well, this whole movie starts playing in my head, right? And I'm watching this and I'm seeing this nurse and she's drawing up a vial and she's finding a vein. And I'm thinking, what have I done? I cannot do this. And the doctor could tell that, my whole confidence had changed. And he said, do not worry. A nurse is going to come to your home and teach you how to use it. We left. He filled out the prescription and left. We got a call from the Circle of Care program that the doctor briefly mentioned. They called and asked us some questions and they ran our benefits. They called back with the copay. Since then, we've switched insurance. We've gone through this process again. They called back with a copay that was way higher than we had with our other insurance. And we said, that's too high. Then they took it and ran it through some foundations and called back and said, okay, then, we've found a foundation to cover the copay. You have no copay. They shipped the medicine to our front door and the nurse called and made an appointment. And the day that Joe met with the nurse, I left him with his mom, who was a retired nurse, because I still didn't want anything to do with this injection. And I went to work. And I regret it because about 5 hours later, I get a phone call from Joe's mom and she's crying. Now, I had asked, of course, what the side effects were, with the doctor. I wanted to know, I wanted to kind of get out of this whole injection thing. Joe's mom was crying, and when she caught her breath, she said, Sarah, Joe wrote his name legibly for the first time in years.
That sounds ridiculous.
I know, just look at chills.
I get to,
Yeah. They were.
If my mom wasn't around, just little steps like that were important to her, and it worked. I was getting really bad off. Luckily, Sarah came. Parkinson makes you cry more, joy, but I get emotional because my mom's not with me anymore, and she really held my hand the whole way. Me and my 4 brothers, they got some problems too, but health-wise, and she really helped with that. But just to write my name clear, I had 2 checks at the bank and the manager called me and told me my checks were being forged. That's how bad my handwriting had got. I couldn't button my shirt in the morning when I was in and off. I couldn't get dressed in the morning. I had to work. I couldn't get out of the house. I get kids out. And I couldn't get up for an hour and a half to get moving. Get in the shower. Couldn't raise my arms and wash the upper part of my body. And then I was suffering through this stuff. And without her, and her asking questions and my mom pushing me to think about your kids, I don't know where the hell I'd be.
Oh.
And it's just, there's things out there that can help.
And she got really excited after she told me and she caught her breath. And she said Joe buttoned his shirt and tied his shoes. She went up to his bedroom and got a tie and Joe tied it. And she was so excited and couldn't wait for me to see it. And about 45 minutes after that, the nurse called. And she told me that Joe had some side effects, that Joe was nauseous.
Yeah, I had a little bit of a gag reflex. I didn't vomit or anything. When the nurse comes to your house, there's a bunch of different doses.
There's like 36 different doses.
And they put it at 0.2 normally when you first try it out. And that seemed to be like a lot of medicine. It hit me pretty hard. Like I felt overwhelmed, and that's when I started to gag a little bit. They put it down to 0.1, and I reacted tremendously to that. I felt pretty much like I could do anything. I relieved the symptoms I was so off. I wasn't, and within 5-10 minutes, I was on again. And that was at 0.1, and that was 6 years ago.
Yeah. And then she said, I think we've even found the right dose, but I'll be back to teach you how to give Joe the injection as well. And since then, I will say that, so many things in our life have changed. Just dating, we had been dating probably 8 or 9 months at that point. And, Joe would make excuses because he didn't want to go get stuck in a restaurant and not be able to cut his food or have me cut his food.
Everybody else would be on dessert. I'd still be on the appetizer. It was so slow. It was ridiculous. But like you said, I call it a Philly special. I coached high school football for a bunch of years after I got done playing. And we always had a play that when we called it or when we run it, it worked.
Yeah.
Well, APOKYNs are fairly special. Whenever, we don't use it all the time. I use it pretty much twice a day. I've never used it to 5 times where you're allowed to. But when I use it, it works. I mean, it's got 95% efficacy. My car in high school didn't turn on 95% of the time. But it works, and we always have it with us.
Yep.
And it gives us peace of mind.
Yeah.
It gives me a lot more confidence.
Joe takes it in the morning. So Joe takes it in the morning because no matter Joe's not digesting his pills. So no matter if he takes 1 pill or 100 pills, they're still not going to digest. That's why he needs that in the morning. And then he'll take it again if he's feeling it wear off. Joe's gotten to the point where he can really tell when his offs are coming, and he'll take it. Joe still is working and running a company with 14 employees. We have 7 kids between us. Joe asked
6 girls, so I gotta be on my game with boyfriends now.
Yeah.
College and high school girls.
Yeah.
It's crazy. Boyfriends come in, they see me playing it off, they're gonna take advantage of my girls. So I'm gonna be on.
We've ridden bikes in Washington, D.C. I mean, I can get him to walk all over New York with me. And he doesn't have that, he doesn't have as much of that apathy, or the fear that I don't want to go someplace and get stuck or be embarrassed, and he's played his father's son's basketball game after he started on this again. I mean, there are so many things that in a quality life that we feel like that Joe has gotten back. And then in 2018, Joe asked me to marry him.
If there are 3 bottles of wine, she said, yeah. but the important thing is that this disease, what I tell people is it isolates you. I mean, I always feel bad during the pandemic. Some people that are alone had this disease. I know it had to be horrible. I mean, exercise is the most important thing, but socializing, I think, is right up there like 1A. When you're amongst your friends and your family, you forget the disease for a little while. But if you're apathetic and you're banged up and hurting and you can't get out of your house, how the heck are you going to see anybody? So that's where you got to find the right cocktail medicines and the right doctors and have the right people around you, because there's this, you can live with this disease and live very well with it. I mean, I think I'm better than I was 6 years ago when I started on this medication. And there's so many other things in the pipeline.
And I don't know how many caretakers have called to reschedule therapy appointments, but I did my fair share of them. But now Joe is doing his occupational therapy as big and loud as LSBT. He's doing physical therapy. He is rock steady. Joe lifts weights for his gait. And all of those extra things that come along with, I mean, it's really a full-time job to fight this disease. And so Joe is doing those things that he wasn't doing before to fight it. And it has made a difference. That, in addition to the medication, and I'll tell you that in 6 years, Joe has not had to up his carbidopa, levodopa, because this has supplemented it where it has failed. And that, to me, is just so hopeful. And I always say to the caretakers and everyone in the room that every minute you get to spend with your loved one is precious. So keep coming back to these events and keep educating yourselves and advocating for your loved one. Go to the doctor and air the dirty laundry of the disease. Because if you don't, the doctor won't know. And there's so many things out there and so many things in the pipeline to help make your quality of life better.
And the best thing about the disease, if there is a best thing, is it's made me prioritize what's important. And because it's slowed me down enough where, you smell the flowers a little bit. And your kids are important, the most important thing. Your wife, making a box good and everything, but it's not the most important thing. And, it's not about you anymore. It's about the people around you, because it's a difficult task, right? For the women and the men that have spouses, boyfriends or girlfriends that have this disease, it's a job for you. You're going through the disease the same as the person who has it, probably more. And for you to stick with your guy or your girl, you should pat yourself on the back, because it's amazing. This in sickness and health doesn't always work for some people. And this is a tough disease, but the people that have it are extremely tough. I mean, I've met a lot of people around the country as you have. And certainly in the Midwest, there aren't as many doctors. They got to travel much further to meet their doctors, and they keep plowing forward. And I want to leave with you're strong and you have a great life ahead of you. It's just going to be a little slower. So what? I mean, we're gonna move a little slower. We're gonna talk in gibberish once in a while because we're slowing down, but as long as you're happy, keep the people around you happy. What else do you live for?
And this is just our story. We have to end with, please read the prescribing information as well on the APOKYN. I know that Chris brought a bunch of literature on the medications that Supernus has. And this is our story. Yours might be a little different, but if you got anything else out of this, just ask your doctor. Oh yeah, well, yeah.
Yes, ma'am.
I just was wondering, are you taking any other dopamine agonists?
No,
Like Neuropax or?
I tried new.
he tried the Nupro patch and it made him so violently ill. And he even was cutting it and trying to use it. And we didn't honestly think that because this was another agonist, we fully expected him to not tolerate it, but he did. And so really lucky.
You can adjust the doses. We found the right dose. For the patch, I couldn't get a different size patch, but it's only like 2 or 3 different sizes. So this one is 36 or 30 some different doses you can adjust to. And it's in and out of your system so quick, you run on a lot of the problems.
That one right there.
Oh, there you go.
Good. If it works for you, it's great. Yes, I am.
What would you say your side effects would be from the drug?
Repeat that question.
What are my side effects from the APOKYN?
Mhm.
Well, initially it was because I had too much of a dose when they were titrating me. I felt nauseated. But other than that, since I found the right dose.
If you're not doing anything.
Well, I say it's a purpose drug. That's a good point. A purpose drug. So when I take it, it's because I'm moving, I'm going somewhere, I'm doing something. Like if I'm sitting around watching TV, watching a game or something, I don't take it because it can make you sleepy. But when you have a purpose and you're doing something, it kicks in and really works well. And I know when my offs are coming, so I don't let myself get in that deep off where I can't even function. I take it proactively and I take it and I stay out of that off. So I went from living like this to like this. And it's really been amazing how consistent I've been with it and how it's helped with the reliability and the predictability. I'm not in deep offs that really ruin my day. And if you can stay out of the offs, you can have a better day.
Dave, you haven't had any hallucinations?
I'd say one time I saw my wife walking around the room banging into the walls. And I realized she had a lot of wine at dinner. Whatever the answer, I was getting together with that one. But no, thankfully I haven't had anything like that. And I still have the sleep issues, you get up every hour or two. But I'm on another drug helps with that. But any side effects of it? No, I've been really good with it, thankfully.
Mhm.
You definitely don't have a low voice.
Oh, good.
So why is that?
Used to.
That's an off. When I did have a low voice because when my job, I'm a government consultant. I manage local municipalities. So I have to give budget talks and stuff. And she'll hear me on a tape or something, and I'm way down, and you can see people reaching out to me, leaning in. So I catch myself. The big and loud helps, yeah. And I got 6, 7 kids, so it's a lot of yelling.
A lot of yelling.
So, where you going? What time you coming home? Because they don't really hear you if you're quiet. So, yes, sir.
You said you had a nurse come and help you get started. How long did you have to adjust with the nurse?
That's the best part of the program. I mean, they hold your hand through the whole process. She called Sarah, and she came to the house. She was the whole titration period because I didn't adjust to the first dose right away. Took about 4 hours. So she sat with 4 hours with me and my mom. And she came back. She's come back. We have a new nurse now because she retired.
Mhm.
And they come to our house. They call, visit us once a month. They'll call and ask how much medication, how's it working? Do you need more?
They stay with you for the entire time that you're on the
It's
medication.
amazing.
I can text her if I have a question about something that might be unusual because we don't have very easy access to our doctor. I know some people are lucky enough to be able to shoot a text to their doctor, and ours, we aren't able to do that. But we can easily reach out to our nurse And they're with you the whole time that you're on the medication. Anytime that there's something going on with it, or if you feel like you need more, they can come out, make sure that they're monitoring your blood pressure if they're upping the dose and that kind of thing. And that I do agree with Joe. I don't know any other medication that comes with your own personal nurse.
We invited her to our wedding. That's how close we got with her. I mean, I had a colonoscopy. I called her. She told me how to handle the medications going into the hospital. You got to be in.
Yeah, if you think about it, in a colonoscopy, you're flushing all the medicine out. So what do you do when you're going in to get that done, right? So she walked us through that and just said, make sure you have it. We carry APOKYN is really easy to carry around too. It's not like it looks like an insulin pen, but it doesn't need to be refrigerated. I keep it in my purse. He'll keep it in a suit jacket. You know, when it's not hot, we'll keep one in the car. So he has one in his office. It's just super easy to have around to carry with you and portable.
And you find a spot and you rotate it around your fatty part, like your hip, the stomach area, maybe a tricep. And once the needle's so small, like I'm one of those big galoots that's afraid of the needles too, but my son's taking the, I never complain. So I take it, she gives me a shot. And sometimes I don't even know she gave it to me because you can only feel it. And
tell them about your mom.
Yeah, my mom, God rest her soul too. She was my secretary when she retired as a nurse, and we all worked in the same building. And I was having it off, and I couldn't even give myself the shot. So I went in the front office where she is, and I had my pants down. She's getting it to me in the hip. But the UPS guy walked in. Big moon staring in his face. The guy never came back with the UPS guy next week. But, we laugh about it and stuff, but I was on again in 10 minutes, so he saw my backside. But it's a great drug. It's a great company that sells it, and
very well supported.
Just ask your doctor about it. That's the least you can do. Ask them if it's right for you, maybe it works. Yes, ma'am.
You were saying what a great company it is. You guys are great advocates.
Thank you.
Thank you.
Thank you.
Thank you very much.
Yes.
Cuter than you.
Oh, thank you.
She's cuter than you.
Not white theater.
Huang that said about the holistic approach. Obviously, this is a very inspirational story. I find it so. But Joe and Sarah, you epitomize and personify the holistic approach of the exercise, the taking care of yourself, the care partners. We've got Lucy and Mo back there. I mean, I knew Mo before he looked anything like that as far as his issues were concerned many years ago, and Lucy as well. But, they're together, and that's a part of it. That's that, again, going back to that holistic approach. I think it was Dr. Weedy here last week had mentioned, or last month mentioned, like if we could just get a pill to fix it. But part of the component is exercise and movement. I mean, the funny thing about Parkinson's, if you will, is that the things that are good for anybody that doesn't have Parkinson's are even better for those that do. So it's exercise, it's sleep, it's hydration, it's your medication compliance, it's your diet. That's the whole picture. And on top of it all, they're very fortunate, just as many of us are here today, to have each other. So thank you so much.
Thank you.
It's fantastic.